Yeah. Just wait a few more minutes, though. See, we've got people joining us, so that's
Absolutely,
good.
yeah. Silencing my phone so that doesn't go off in the middle of everything. Did you and Matt train together then?
No, I mean, I only spoke to you, Matt, with the post-grad stuff.
Yeah.
Didn't I? That's the only time.
All right, okay.
Met you recently.
Yeah.
Where did you train, Charlotte?
Yeah, I trained at UE.
Okay.
Yeah.
No, I was at Exeter.
Right, yeah. Yeah, all fairly local. Yeah, quite well. A few people that I trained with, I think, headed your way after finishing. But I don't know if I would know anyone off the top of my head that's still there.
No, we get quite a lot of UE grads. It's mainly, I'd say our department's mainly like Exeter, UE and Cardiff grads.
Yeah, I was going to say that the last few years you've had quite a few that have come down to you, haven't we?
Yeah, we do. Yeah, we've got quite a few of the sort of fairly newly qualified Cardiff grads, and our manager is actually a Cardiff grad.
From how long ago, Matt? Do you know?
Oh, how old is he? He's in his late 30s, so I think he's probably from maybe about 15 years ago or so.
What's his name?
Adam Turner. I know Karen remembers him.
No, I don't know. Don't think I know him. I taught in the school between 2000 and 2005, and then I left to go back to clinical, so I may have missed him. Okay. I've got a good number of people who turned out. That's great.
Lovely. Just let me know when you want me to start.
Yeah, I think. Can everyone hear us? Yeah.
Yeah.
Brilliant. Okay. I'm going to let sort of Charlotte introduce Matt in a few minutes, because Charlotte's taken the lead on organising the session today. So I want to just at the start of everything really say thank you very much to Charlotte, and thank you very much to Matt for joining us this evening. I think it's great for you to be able to hear someone that's very recently, or still is, a postgraduate student with us here at Cardiff. And I think really I just wanted to raise the profile really of postgraduate study, and that is to sort of get you to think about, you know, May, June is not the end of your period of study, and for some of you, you may be looking to join us to do your MSc. My understanding is that the university are lifting the expectation that you should be qualified for 2 years after your bachelor's degree before you start your MSc. So that is being lifted. So, you know, there is nothing stopping you from qualifying in the summer and putting an application in to come back and do your MSc starting in September of this year. Obviously, there's that little thing called money to be able to pay for it. I earlier sent you all links to the full-time MSc course and the part-time MSc course, and also to the postgraduate certificate in radiographic reporting. I think also, you know, we seriously need to think about some of you moving straight on from your undergraduate degree and moving straight into PhD study. It's a practice which occurs extensively in the STEM subjects, in science and engineering, A lot of students go straight from their undergrad and straight into their PhD. It doesn't have a significant history within allied healthcare professionals, but there's no reason why you can't do that. And for those of you that are interested in going on straight to do your PhD, then you will need to contact Carly Regan or her deputy at the moment to discuss your opportunities of potentially doing a PhD. Obviously, then there's the cost involved, but again, my understanding is there is no concern or no worry that you may not have had any clinical experience. You can go straight on and study your PhD, but obviously it's the money is the issue. But I'm sure the researchers based down at Eastgate House would be able to direct you to appropriate sources of funding, or whether you want to fund yourself. But really, it's just to make sure that you have postgraduate study on your horizons, really, because, you know, as Matt will contest probably, coming back to Cardiff to do his postgrad has been the next step on his professional career. I'll shut up. I shall pass over to Charlotte.
Thanks, Martin. First of all, I just want to say thanks to everyone for joining us this evening, and thanks, Matt, for offering this session. Hopefully it will be a good session to put down for CPD for you all, especially since I know you're just at the end of completing your streamlining applications. So hopefully this is something that you can put on there, a CPD, and I have done a certificate that I will hopefully send out to you all after joining the session today. We are recording it as well, so if anyone else joins partway through, they'd be able to catch up, and I'll be able to make that available to everyone once we've finished. So I'm going to let Matt actually introduce himself. I will just say, hopefully this is going to be a fairly interactive session, so please don't be afraid to get involved. I think the best way to do that is to write in the chat box, though, as opposed to turning your mics on, just because there's quite a large number of you. It'd be quite hard to manage if not. So if people want to write in the chat box and everything, please feel free. But I will pass over to Matt to introduce himself and to start the session.
Thank you, Charlotte. Cheers. Hi, everyone. Thanks for joining me. I'll just start with a little bit about me first. So my name is Matt. I'm a reporting radiographer at Somerset NHS Foundation Trust, which is based in Taunton in Somerset. I did my undergraduate degree at Exeter and I graduated in 2014. I did 2 years as a plain film radiographer, 2 years as a CT radiographer, and then I got funding from my department to go and do reporting training, which I chose to do at Cardiff. I've done my MSK, which I did in the year of 2018-2019. And I've been working as a MSK reporting radiographer since then. And I'm actually a master's student at the moment back at Cardiff, doing my chest X-ray and abdomen X-ray reporting, and working sort of towards research stuff to later do a dissertation. Other than that, I've done a few guest lectures at Cardiff already on the previous year of the MSK reporting course. I've done some guest lecturing at Exeter. And I also do a bit of work with Health Education England and the College of Radiographers on e-learning. So I've written some online modules about theatre imaging, which I think have just been published on the College of Radiographers e-learning for healthcare system. If you've ever used that, it's quite good. It's something that I did in practice for reporting. It's got quite a good image interpretation section. But anyway, enough about me. Can all of you see the screen that says interesting cases?
Yeah.
A few of you say, yeah, that's fab. Okay. So Charlotte sort of mentioned about this being an interactive session. This is a PowerPoint I designed really for teaching trainee reporting radiographers. There is some stuff in here which is probably a little bit difficult. So I don't want any of you to worry or feel disheartened if you can't sort of see some of the abnormalities, because, you know, this is stuff that's designed to test sort of a seasoned reporter. So don't worry about that. But I think what would be good is if you guys can sort of volunteer some answers. I'll give you sort of 30 seconds or so to look at each case. I've got the chat box open so I can see what you say, and we can sort of have a little bit of discussion around what we think is on each one. So let's move on to case number 1. So hopefully you guys can see some shoulder x-rays. So I'll just give you 30 seconds or so, just have a quick look at that. If anyone wants to say what they can see, we'll have a little chat around it in a minute. I'll say so. These are all x-rays from my department. None of these are taken from online. And what I've done, even if I've not reported these myself, I've gone back and written a report as I sort of would if I'd hot reported it. So all the reports are written by me. Okay, so we've got an offer of displaced humeral head, and I think that's quite a good observation. That isn't what it is, but I imagine, I think I can actually, if I draw on this, we'll see if you guys can see it. I think what they're probably referring to perhaps is this. Can you see the pen?
Yeah.
Lovely. So that sort of abnormality there is what I describe as sort of, it's a sclerotic and cystic appearance. That is really common in somebody, I haven't put how old this patient is, this is quite an elderly lady. That is sort of the bony manifestations of something called rotator cuff tendinopathy, which is just where you've got four tendons of the rotator cuff, and it's just where some of them insert. So you've got a bit of degeneration of the rotator cuff, and it's caused some bony degeneration. Just erase that. So actually, guys, where the abnormality is here, and I will point out this got missed. This is a patient that's come from the GP, and this has actually been missed by the radiographer that took it. If I direct your attention to the Y view, and if I draw a line through the glenoid like that, and if I draw another line through the scapula, so those are not straight lines at all, but those two lines are supposed to be one. So this patient's actually got a scapular fracture. It's a fracture of the scapular blade. And if we look at the AP projection, I'm going to outline a couple of things here. So these are two bony fragments from that. So what's essentially happened here is the fracture's extending through the body of the scapula, and then part of the scapula has displaced posteriorly and sort of superimposed over itself, which is what's causing these sclerotic appearances on the AP projection. So if I get rid of my annotations there. So let's just have a look at the next slide. So this is the report I've written. So first thing I do is identify the orientation of the fracture, transverse / oblique. Where is it? Through the blade of the right scapula. A bit more localization, it's at the level of or just inferior to the glenoid fossa. There's evidence, so microfragmentation is sort of a term I use when it's like something being comminuted when it's in multiple fragments, but the fragments are quite small. It's just a term I use because I think saying something's comminuted sort of has certain connotations that it's quite a badly fragmented fracture, whereas this actually the fragments are quite small. So it's impacted because the blade has sort of moved behind itself and slightly above where it should be. And as we discussed when we looked at the initial images, it's posteriorly displaced. When you talk about displacement, it's implied you're referring to the distal portion of the bone. But in this case, because we're talking about sort of an irregular shaped bone, on what is essentially an axial structure rather than an appendicular one, I've sort of specifically said that it's the inferior fragment that's displaced and not just said posterior displacement, just to be a bit more thorough. If I go back, you also see old fractures of the 7th and 8th ribs. Just there and there. So not acute, not really, sort of there, sorry. Not really pertinent to the patient's acute presentation, but it's worth mentioning nonetheless. And that bottom paragraph there is just talking about those changes identified on the initial looking at the image, which are those rotator cuff tendinopathy changes. So anyway, guys, well done. All of these fractures kind of have all of these cases have learning points. So the learning point for the first case is that actually, as sort of Martin said in the chat, scapular fractures are quite rare, especially in that kind of orientation. And my advice to, not necessarily reporting radiographers, but any radiographer that's doing plain film, is if you've got a standard way of doing things in your hospital, it might be worth considering specific projections based off of the individual patient's presentation. So in my hospital, we don't do Y views as standard, we do axial projections. And in this case, because the patient has presented with scapular tenderness, I would hope that the radiographer who's taken the imaging would identify that and think, well, actually, the best way for me to identify a potential scapular abnormality is with a Y view. Right, case number 2. So have a little look and tell me what you think's wrong with this patient. Oh, the clinical information I've given you is the actual clinical information that came on the request, which is why you'll notice there are so many typos in it, because apparently referrers in Somerset can't spell. I'll say as well, guys, if I'm more than happy, if anyone's got any questions as we go along, please do just ask. I'm happy to sort of break away from what I'm talking about to answer stuff as we go along. Yep, lovely. So we've got a couple of answers there. They're both right. So for a good spot, the patella is much too superior as to where we'd expect it to be. So actually, that has a specific name. It's called patella alta, and that can be for congenital reasons. In this case, it's actually traumatic. So if you think about your anatomy around the knee, you've got the quadriceps tendon sort of here, and then you've got the patella tendon here. Okay. That. Now you'll notice in this area there's a lot of soft tissue swelling, and that is actually because this patient's patella tendon is ruptured, and that is what's causing the patella to move superiorly. So in your normal patient, you've got the quadriceps tendon and the patella tendon both exerting a force on the patella, and that's why if you've got a patient with a patellar fracture, the two fragments are quite often pulled in opposite directions. In this case, it's not the tendon, it's not the patella, sorry, that's been injured, it's the tendon itself, and there's actually no bone injury here. So if we look at what I've written about the report, significant patellar alta with associated swelling in the infrapatellar area. The appearance is consistent with a patellar tendon rupture. Obviously, this is something we can infer from the bony appearances, but we can't really say how bad the tendinous injury is with an X-ray. in the first instance, I tend to recommend an ultrasound. An MRI would also be useful, but I think an ultrasound is a sort of better frontline investigation. It's important to say there's no bony injury demonstrated, because that would be the kind of thing you'd expect. Again, in the knee, you don't necessarily have to have like a big prominent fracture. You can get really subtle fractures like second fractures or reverse second fractures or arcuate ligament fractures off of these sort of circled areas. They can be tiny, tiny bone fragments, but they actually have really debilitating effects because they've got a really high incidence of anterior cruciate ligament damage. Something I like to do with all of the x-rays I report is, despite the fact of whether it's a trauma film or not, I always talk about the appearances of the joint. I always interpret everything like it's a GP film, really, that I talk about the arthritis and everything, because actually you have the potential to save the patient from having to have another investigation down the line. So, you know, if this patient now goes to their GP and they've got knee pain with sort of an osteoarthritis sort of feel about it, we can actually say, well, we already know they've got very mild osteoarthritis. It's unlikely to have changed in this time frame. Do we really need to x-ray it again? Or if we know that the tendon is the problem, can we look at doing a non-ionizing radiation examination like an MRI to have a look at that? Okay, so had a subsequent ultrasound as recommended, and that's the report of that. So not only have they got a complete tear of the patellar tendon, they've also got a partial tear of the quadriceps tendon. So not a great combination. And the learning point for this is patellar outer. As I mentioned previously, it can be traumatic, but it can also be congenital. There's a sort of woolly way of measuring patellar outer that I think MSK radiologists like to use, called the Insel-Savalti ratio. But actually, I don't use it. It's completely reliant on the knee being in a specific amount of flexion. I wouldn't use it. It's just, I'm showing you it as a bit of color, just because it's interesting to see if there's an actual measurement for it. You know, I more just eyeball it and say, well, actually that patella is not where it's supposed to be, so it's patellar outer. Patellar outer has an opposite, which is called patella baja, and that is an abnormally inferior patella, so that might be potentially caused by a quadriceps tendon injury rather than a patellar tendon injury. Okay, case number 3. So have a look at that one and see if you can sort of at least just sort of tell me where the abnormality is. You don't necessarily have to say what you think it is, but tell me what you think doesn't look right on that image. Yeah, so Alice is very well done. She's identified the issue. So the pubic symphysis doesn't look right. I think if everyone sort of has a look at that, you'll notice, even comparing it to its surrounding bone, it's a lot more sclerotic around the joints. And actually the joint itself, rather than having sort of two normal parallel straight lines as we'd expect, it's got sort of quite a jagged sort of furry appearance to it. So one differential for this would be an infection in that area that's causing osteomyelitis. The clinical information gives you quite a big clue as to what this is. So the fact that this patient's got chronic pain and the fact that they're postpartum, meaning that they've had a child, means that this is likely to be something called osteitis pubis, which is sort of a chronic inflammation of the pubic symphysis. It's most common in women that have had sort of natural childbirths, because the pubic symphysis undergoes quite a big strain during the delivery of a child. You can see it post sort of other kinds of trauma, and you can see it post-infection, like we've also discussed. You can also see it as a stress injury in certain kinds of athletes if they're overexerting that particular area. So periarticular sclerosis, abnormal joints suggesting erosion, that all points us towards some kind of an inflammatory process. I've also mentioned the patient's got Coccyprofunder, and that is basically where, if you notice, usually you would expect the acetabulum to be here, but the acetabulum is there, and it's crossing this, which is the ilioischial line, and that's how you grade it as Coccyprofunder. If it crosses this line, like the iliopectineal line, it's something called protrusio acetabuli, which is usually associated with sort of really bad congenital disorders like osteogenesis imperfecta, or potentially chronic inflammatory arthropathies like rheumatoid. But we will move on. So we've already talked about all that. You can have systemic inflammatory causes as well, and those are usually seronegative spondyloarthropathies, which is your stuff like ankylosing spondylitis, psoriatic arthritis, stuff like that. Okay, case number 4. I'll say as well, guys, none of these are normal, because that would make for an extremely boring presentation if I just got you to look at a normal x-ray for 5 minutes. So they all have something, and the idea is that one of the things that I want to sort of test you guys on is something called satisfaction of search. So to say this has an obvious abnormality, which I hope you'll all appreciate, but that doesn't necessarily mean it's the only thing there. So yeah, Elise has very astutely noted there's a whopping great spiral fracture going through the humerus. So that's great. That's, as she said, that's the obvious fracture. Okay, so Alice has talked about supracondylar. There isn't a supracondylar fracture here. That is predominantly, supracondylar fractures have a bit of a sort of bimodal distribution. So they are most common in pediatrics, but they have a sort of second peak in really, really elderly people that have got really bad osteoporosis. Oh, lovely. Yeah. So very good call. Somebody's pointed out there is also a fracture here. So that is the important thing to note, because actually there's a fracture that's involving the greater tuberosity, but I'm also suspicious that it's going across the surgical neck of the humerus. And that could potentially have, quite a different outcome if they don't treat that as well as the fracture of the humeral shaft. So yeah, that's a really, really good one to spot. Well done. There we go. So again, lots of descriptive terms. There is a spiral fracture of the midshaft of the right humerus with mild medial displacement. So I can say it's medial because on the AP projection, the distal fragment has moved towards the body, towards the midline. Additionally, communicated fracture of the greater tuberosity, and I'm suspicious that it extends into the surgical neck. I would suggest doing specific pictures of the shoulder, because I don't think on this, I don't think on AP humeral views you can really see the head of the humerus as well as you would want to be able to rule in or out if that fracture involves the surgical neck. So easy learning point for this one, as I've already said, satisfaction of search. And I want you guys to bear that one in mind, because actually that's something that's going to come into a lot of the later cases. Here we go. Yeah, Elise has got it. So there is a calcified abdominal aortic aneurysm, which was previously unknown about. And that is one of the key findings. So there are two findings on this. And sort of, guys, this is what I was referring to at the beginning, where I don't, you know, necessarily expect you to be able to see everything or describe everything, because this is a very busy image. There is a lot going on. And this is, again, a pathology that is notoriously hard to see. Okay, so if we look at the clinical information, query sacral insufficiency fracture. So this patient doesn't have a sacral insufficiency fracture. They are very hard to see, and they kind of appear in this configuration. They can appear as sort of sclerotic lines. And the other way of seeing them is if you look at your sort of arcuate lines, which are here. Okay, they kind of get this sort of, ooh, a bit too much, sort of fuzzy appearance like that. Now, this patient doesn't have insufficiency fractures of their sacrum, but what they do have, and it's hard to appreciate on this one as well, because you've got a lot of artifact coming in from the bed, is they have a traumatic sacral fracture, which is just here. I draw around the cortex of the sacrum. So this is sort of, the sacrum sort of fractured and almost impacted into itself slightly. Other than that, the patient has a few more going things on. You know, this is an elderly lady. She's got degenerative disc disease. She's got both antero and retrolithesces of her vertebrae. So antero, forward, retro, backwards, disc disease here. So we've got end plate sclerosis, and we've also got disc space narrowing, and we've got osteophytosis as well. And then if you look at the height of the actual vertebrae on L3, you can see it's a little bit reduced to the front. Vertebral fractures, especially if they are insufficiency or osteoporosis related, they're quite hard to date. I generally say if it's acute or not based off of if they've got any previous imaging. So if that wasn't on a previous x-ray, then I'd say it's occurred at some point during the intervening period, unless there's one for unless there's one where you can actually see the fracture line, which you don't tend to do unless it's sort of like a burst fracture. Then I would sort of be a bit more on the fence about trying to accurately date it. So, well, the question is now, what next? So we've got two things here that actually need a bit more imaging to be able to assess. You don't necessarily have to do anything about treble A's if they're known about. This woman has never had any imaging. So if we go to the next one, we can see what I did. Now, this is a very wordy report. Again, I said it's a busy image. There's a lot to talk about. I use a structured reporting method for spines especially. So I talk about alignment, I talk about bones, And then I talk about joints, or you can also say cartilage, so sort of ABC, and then S for soft tissues. It's a sort of approach I use. So we talked about retro and anterior listheses. They're sort of the kind of thing you'd expect in this patient. You don't necessarily, they're worth talking about, but they're not urgent findings. Something that relates to that I've mentioned in here, it's something called Bastrop Syndrome that some of you may have heard of. It's basically, if I go back, I can show it to you. You can't see it very well because of the bed artifact, but if you look at these spinous processes in the lumbar spine, they're really squashed together. They're starting to get a bit sclerotic, and they're also starting to hypertrophy. That is Bastrop Syndrome. It's basically a increased lordosis in the lumbar spine will make the spinous processes rub on each other, and that will cause a sort of bony reaction. Like any two bones rubbing on each other, it will cause sclerosis, and it will cause the equivalent of osteophytosis in that area, which is just the actual process is just getting sort of bigger to compensate for the sort of trauma they're getting. Tend to take a cautious approach with treble A's unless the patient's actually got any abdominal symptoms. I think a Doppler ultrasound is more than enough to look at it. Depending on your particular hospital, you will either sort of go for CT or MR. We're a very CT-led department here. So they went for a CT of the sacrum, and they also completely ignored my advice about doing a Doppler and did a CT angiogram instead. But that means we can actually see it a little bit more. Learning point, again, satisfaction of search. Sacral fractures are really, really difficult to see. They're very easy to miss. So please don't worry if you didn't see that. Again, I wouldn't expect you to. This is a really important thing for you guys to know, because this is classic exam material that they will stick a patient with treble A in. Because it's not, people tend to be a little bit blinded in that they will say, oh, it's a lumbar spine x-ray, and they look at the lumbar spine all over, there's nothing wrong with it, it's normal, move on, and actually the patient's got a whopping great aneurysm, and that's the critical finding. So we've got a sagittal bony reconstruction for the CT, and here's the sacral fracture, and also there. Okay, and then here we've got the aneurysm. And I've got to say, the aneurysm looks a lot more impressive on plain film. It's a little bit boring here. It's not nearly as big as I thought it would be. Okay, case number 6. And again, guys, this is one I think I hot reported the morning after it was done. So it was done in the middle of the night, or sort of late in the evening, and this was missed by A&E, and the patient was sent home with no orthopedic follow-up. And one thing I'll say about this one, the referring clinician actually did a very good job with the clinical information. So the clinical information is very pertinent. So just focus on that particular area. All right, I'll give you guys a few more seconds because this is quite a tough one. So it's a pediatric patient. I think that's the first thing we can all notice. Head of the second metacarpal, close but not quite. Although that could be a typo, but it's actually a third. So it's just here. There is a tiny, tiny little bone fragment. Any ideas what soft tissue attaches there? So all of these joints, whether they are sort of interphalangeal or metacarpophalangeal, have collateral ligaments which stop sort of abnormal movement in either of these planes. So that is actually, I'll get rid of the ink so you can see it. That is an avulsion at the insertion of the ulnar collateral ligament of the third metacarpophalangeal joint. But yes, also, yeah, very true. Extensor and flexor tendons can, or volar plate insertions could are the usual suspects for avulsion fractures. But this is also a relatively common site for things to come off. So because this ligament prevents abnormal movement this way, or what we can say is that what happened to this patient is that their finger was probably forced in the direction of the arrow, and that's overloaded sort of the tensile strength of this ligament and pulled the bone off. Like I said, this was missed by the A&E doctors, so I wouldn't worry if you've missed that. So separacific fragment visualized at the medial aspect of the head of the third metacarpal. This is something that always messes with people's heads. Something to remember is that when we take wrist or hand x-rays, we technically take them PA, because this is lateral and this is medial. Okay, which always confuses people. So this is the medial aspect, even though you look at this and in your mind this is lateral, but actually lateral is always where the thumb is. Oh yeah, we didn't mention that, did we? There's a little fracture here, but that's old. That was on previous imaging. Okay, there's a zoomed in shot because I think it was really hard to see on the main one. So it's just there, right in the middle. Okay, case number 7. So they've given us quite a lot of information, which is quite nice. One of the biggest bugbears for reporting radiographers and reporters in general is poor clinical information, because this is something that's sort of been especially clear to me starting to report chests, is that sometimes you cannot say what something is without the context in which you're seeing it. If we take chest, for example, consolidation could be a manner of things. It could be infection, but actually in the context of trauma, an area of consolidation in the chest could represent a pulmonary contusion. That's just sort of a way of me trying to put it into a context you guys can understand. It's just important to know whether the patient's had an acute injury, where the pain is, what the mechanism was, and if they've got any underlying problems. So I'll just start explaining what these two things are, Ehlers-Danlos and Bertelottie, while you guys are just still having a look at the pictures. So you might have heard Ehlers-Danlos syndrome. It's a little bit like Marfan's. It's a collagen connective tissue disorder. Patients are more prone to things like aortic aneurysms and stuff like that. Bertelottie syndrome we'll talk about a little bit more after we've gone through the appearances on the picture. It doesn't relate to the perceived pathology here, but it's just an important thing to consider. So the abnormality is here. Okay. Now a lot of people are going to look at that and think, oh, you know, this patient's got a fracture of L4. A little chunk's been taken out of the anterosuperior aspect. So this is actually a normal variant, and you can tell it's not an acute fracture by the fact that it's got very smooth sclerotic margins. Now this is something called a Limbus Vertebra, and that is actually caused by the apophyseal plate where the vertebral body grows, which you get at the end plates, sort of appear as little lines like that. The disc has actually herniated through the growth plate and has cut off this little bit of bone. So there's a bit of disc here, and that stopped it from uniting with the rest. So basically, it's just a persistent accessory ossification center. It's not something you need to worry about, but the important thing to recognize is actually it can act as a mimic for an acute pathology. Going back to Bertelottie syndrome, so you might notice that if you look at the patient's vertebrae, you've got T12, 1, 2, 3, 4, 5. Anterior. I think I can see what you mean. This patient doesn't. So this patient's quite young. They're in their, I think they're sort of early 20s. You don't tend to see, there are a few causes for anterior. Basically, the vast majority of individuals, it's degenerative. So you have facet osteoarthritis, and that causes a kind of buttressing effect where one vertebrae can slide forward on top of another. In younger patients, it certainly can happen, and it's due to a spondylitis, which is a defect in the pars intra-articularis. So you'd see sort of a loosened defect here, and that can progress into a bigger defect that allows the vertebral body to go forwards. Bertelottie syndrome is to do with this L5 vertebrae. And you'll notice that this L5 vertebrae looks a bit strange, and that is because it's undergone something called sacralization. So this is a lumbosacral segmentation abnormality where the fifth lumbar vertebrae has partially joined with the sacrum. And Bertelottie syndrome is where the particularly large transverse processes that this vertebrae have formed a false joint or pseudo-arthrosis with the iliac wing. And this can basically, like any joint, it can become degenerative and it can present with pain. I've been in a theatre case where a spinal surgeon has done a specific joint injection of this pseudo-arthrosis, which is quite interesting. They're relatively common. You see segmentation abnormalities. You can see them up here as well, where you get sort of little hyperplastic ribs that just stick out like this. And you can get them at the cervicothoracic junction. I'm sure you've all heard of cervical ribs. That's just another kind of segmentation abnormality, but that's cervicothoracic rather than lumbosacral. So what I said about this one, normal anterior alignment. So I've talked about my alignment. It's very mild scoliosis. When you define a scoliosis, you define it by its convexity. So where the convex surface is. Vertebrae preserved in height, there's no evidence of fracture, but it's worth mentioning the limbus vertebrae just to tell the referrer that it's not a fracture. And we've already talked about all this, guys. Lumbarization, you can get, so that is sacralization of L5. You can also get lumbarization of S1, and that's how you end up with 6 lumbar vertebrae. They're both associated with their own problems. I know a lot of people with sacralization of L5 end up with back problems because the forces that are usually go through L5 go through L4. And where L5 has really strong ligamentous and tendinous attachments with the surrounding iliac crests, the L4 vertebral body is a lot more sort of loosely attached to surrounding structures. So you can end up getting really bad overuse and subsequent disc disease of L4, L5. Oh yeah, they're related to Schmall nodes, which is basically, if this is a vertebra, like a vertebrae on a lateral projection. Small nodes are little herniations like that go in from the disc. And they're a normal variant. Okay, here we go. Again, we've got a pediatric patient here. So if everyone remembers their critol or crito, then have a little systematic look through this one and tell me if anything's missing. So while you guys are looking, I'm going to start labeling our ossification centers. Oh, thank you, Martin. Martin's given you a little helping hand there. So if we go through them, we've got capitellum, which is actually fused with the main part of the humerus at this point. We've got the radial head, which is still separate. We've got the internal epicondyle, the trochlea, the olecranon, and the lateral epicondyle. And if you can appreciate this, guys, we can actually see there's all these nice smooth areas, and then this looks a bit weird. Okay, and now if we look at the lateral, there's not supposed to be anything there, is there? So this is actually the medial epicondyle. It's similar sort of process to a Salter-Harris. Oh, there we go. Rhiannon got it. Well done. It's similar process to a sort of Salter-Harris 1 fracture, where you basically have a sort of cartilaginous fracture through the apophyseal plate. So because this is a growth center that isn't growing the length of the bone, it's growing the width. It's an apophysis and not an epiphysis. The apophysis has come off and it's trapped within the joint. It's really important that these are picked up because they can really damage the joint when the bit of bone is sort of floating around in there. And it's especially important when you've got a patient that's younger with much smaller apophyses, because the little bits of bone can come off, they can get trapped in a joint, and then they're not picked up. And because the reason they're not picked up is because at that point the apophysis is still mainly cartilaginous. But what will then happen while it's in the synovial fluid, it can revascularize and continue to grow, and it will grow into a bony growth within the developing joint, and it will do a lot of damage. So let's go on. So separate ossific body present within the joint space between the proximal ulna and trochlea. There's a fragmented abnormal appearance to the medial condyle. So it's a fracture through the epicondylar apophysis, and this got an urgent orthopedic opinion. So they took this patient for a CT, and then they went for surgery that evening, I think, to have it sort of open reduction, have it taken back on. I think they had it sort of K-wired back on as well, so they insert a wire through here once they've put the thing back on. This patient's relatively close to fusing anyway, so I think they had quite a good outcome because they didn't get any growth arrest. Okay, we've already talked about that. Case number 9. So I'll say, guys, there are 20 cases. Some of them there's more to talk about than others, but I can sort of try and move through them a little bit more quickly if you like. Have a little look at this one. I'll give you a clue with this one as well, that this patient is being treated for prostate cancer. Yeah, lovely. Great stuff, Alice. It's a pathological fracture through the left sort of iliac crest and iliac bone. You will sort of notice, you can obviously appreciate the fracture lines really well, but at the same time, they are quite smooth. And that is because this fracture was already known about. So the patient's had a previous pathological fracture, which has healed back together. You can see the underlying bone does not look normal. It's very sort of what we describe permeative or moth-eaten appearance. Some bits of it are too bright, some bits of it are too dark. If you look at the acetabulum, that's a sort of really nice indicator on the left of that permeative appearance. And here, there's probably a little bit of periosteal reaction as well. Here, there is an area of increased density. So this patient has got mixed osteoblastic and osteolytic metastases, which are quite common in prostate primary malignancy. No acute fracture, I should hasten to add. So they've presented, this looks essentially like it did on the last x-ray they had. But the important thing which you guys got is recognizing that it's a pathological fracture. So again, I've kind of gone through this, but this is my actual report. So I've said there are pathological fractures, and I've talked about the underlying bone. So it's a mixed lytic sclerotic permeative pattern in the left hemipelvis, in keeping with previously noted metastatic change, periosteal reaction associated with the pelvic brim, sclerotic region of sacrum. Now, this bit actually here, I'm going to be perfectly honest. I reported this and I was like, there's a lot going on. I think I'll just show it to one of my consultants just to get a second opinion. And my consultant was convinced that this was expansile, like an expansile appearance of the sacrum and the coccyx. I'm going to be personally honest, I disagreed. I think it's just a bit of poo in their rectum, but she said that, so I just put it in to be diplomatic. Right, anyway. This is one that I had in the hot reporting pile. And again, this is something that you really don't want to miss if you're reporting an X-ray. So again, the referrer has done well with the clinical information here. This is really helpful clinical information. So Rhiannon said osteomyelitis, which is absolutely not a bad shout, and it could quite easily be osteomyelitis, but it's not. It's something very similar, and there's quite an easy way to tell that it's not osteomyelitis. Yeah, lovely. So really good description. Destruction to bony trabeculae in the head of the third metacarpal. So this is where the abnormality is. Okay, so lytic appearance. What we just looked at in the previous one is quite sort of transferable skills. Permeative appearance. This isn't sclerotic though. This is lytic. You know, you see a lytic appearance, you always think metastases. Metastases do happen in the extremities. They are quite rare below the elbow and below the knee. It's sort of known as the sort of t-shirt and shorts distribution of metastases, that they don't usually go to areas below either of those in the extremities. Like I said, this could quite easily be osteomyelitis, but the reason I know it's not is because if you look at the base of the proximal phalanx of the sort of middle finger, you can see that there are also changes there. So this is not an infection of the bone in first instance. This is an infection of the joint. This is septic arthritis. But that has actually, it's septic arthritis that has subacute. It's not been dealt with at its initial presentation, or the patient's just not coming to hospital, and it started actually dissolving the underlying bone. In its initial presentation, septic arthritis you can't see on x-rays. So it's always a bit of a bugbear, because the first thing they should do if they think the patient's got it is to do an arthrosynthesis, or in layman's terms, a joint aspiration. So this is your phalanx, and this is your metacarpal. Okay, now this is the joint, synovial joint, and this is articular cartilage. Okay, and usually what will happen is the cartilage doesn't go all the way to the edge, which means that when you've got an infective sort of process, it will attack all of this evenly, but you'll see it here and here and here and here first, because it doesn't have to get through any cartilage first. Yeah, it's a good shout there about the gout. A gout could quite easily cause similar symptoms. Get rid of my drawing. So what's happened there is the patient's got an infected joint and it started dissolving. So this really needs treatment, because actually even now, if they treat this, it's going to have a residual deformity, and it's going to cause secondary osteoarthritis. Like I said, the clues in the clinical information: swelling, no injury, hot and red, bony tenderness. You'd be thinking, from the clinical information, you'd be thinking septic arthritis, you'd be thinking gout, and you'd be thinking what used to be called pseudo gout, which presents with a similar onset to gout. It's actually called something much more complicated now. It's calcium pyrophosphate dihydride deposition disease. But it's kind of easier to keep calling it pseudo gout. Right, so looking at the reports, no previous imaging, so I had no idea what it looked like beforehand. There isn't any injuries, answering their clinical question. Abnormal contour, sort of suspicious of erosion and destruction of subchondral bone. And what I can say with more confidence, because of the clinical information they've given me, is that these appearances are really worrying for septic arthritis, and this patient sort of really needs to probably go for a washout of the joint and have some antibiotics. Something I've talked about, learning point, you can't really see it unless it's subacute. So probably between a few days and a week, it will start to show up on x-ray, depending on how aggressive the pathogen is that's in the joint. First thing they need to do if they suspect it is stick a needle in the joint. Right, case number 11. Rather horrible looking ankle. So I hope you can all appreciate that this is not what an ankle is supposed to look like. And the clue for this really is what we just talked about on the previous X-ray. So we can see there's a lot of swelling. You know, I'm being a bit mean here because I had sort of previous CT and previous X-rays to look at. You know, chucking this to you blind is quite a difficult call. So again, osteomyelitis is not a bad call, but using the knowledge we've sort of gained from looking at that previous X-ray, we can say that the joint surfaces are damaged and the sclerotic changes are both sides of the joints. So this is what happens if you don't treat septic arthritis. This is what happens to the joint. So you've got permanent deformity. There's been destruction of the tibial plafond. There's been destruction of the talar dome. This fracture was new. It's new since the previous imaging, but it's not new because it's got quite sort of smooth margins again. I hasten to add, this patient was not walking around. They were in a wheelchair because I don't think anyone with the sort of best of intentions could actually walk around on that ankle. You'll note this in some ways looks the opposite to the previous image, and that's because while initially the pathogen will cause destruction and a lucent appearance because it's destroying the bone, when the pathogen is gone, the body will attempt to repair itself by just copiously laying down calcium, and that's what causes the sclerotic appearance. So again, I've gone through that. So I can happily make this presentation available for you guys if you want it, if you just sort of wanted to read through my reports, just because I don't think there's a great deal to be gained from me just reading what I've written again. So we'll go to case 12, which is a nice little bone lesion. And again, you've got a sort of systematic approach you can use to deciding what a bone lesion is. And again, I don't necessarily expect you to know what it is, but this is quite an easy one to call because there's literally only one thing that looks like this. Bone cyst is not a bad call at all. If it didn't have that lump of calcium in the middle, I would agree. I'd say this would be one of three things. It could be a pseudocyst, which is just a sort of morphological normal variant in the trabecular pattern. It could be a simple or unicameral bone cyst, which are both synonyms, or it could be something else, and the something else is what this is. So around, I say chondrosarcoma, it's absolutely always important to think about aggressive malignancies like chondrosarcoma. And chondrosarcoma is not a bad shout in the sense that there is internal calcification, which can happen with cartilage-based lesions. If this was a chondrosarcoma, I would expect it to have what we'd call a intermediate or wide zone of transition. So things you want to talk about when you're looking at a bone lesion: zone of transition, i.e., does it transition from normal to abnormal bone in a sort of discrete way, or is it a more hard to tell where the border is? We want to say whether it's got a sclerotic or a non-sclerotic margin. We want to look at the pattern of destruction. So again, is it well circumscribed, or is it hard to see whether sort of, is it moth-eaten or permeative? We want to see if there's any periostitis, periosteal reaction that's associated with it, because that would indicate a more aggressive process. Is there a soft tissue component? Again, when you've got something like a sarcoma, you usually expect there to be an associated soft tissue abnormality, and is there calcification? So narrow zone of transition. geographical pattern for destruction. This lesion is well circumscribed. There's no periostitis. There's no soft tissue component. There's no evidence of cortical expansion or breach. And it's got intralesional calcification. And this type of intralesional calcification is called a cockade sign, which is named after, I think, like a shield-shaped badge or something really random. This is what we call pathognomonic for an intraosseous lipoma, but it only appears like that in the calcaneus. But if you get something like that in the calcaneus, it is 100% an intraosseous lipoma. And that's that sort of systematic approach we've used. Yeah, sorry, another thing I didn't mention, you talk about the matrix. So is it lucent? Is it what we call chondroid, where it's cartilaginous? Is it fibrous? It has sort of a ground glass appearance, or is it sclerotic? Because fat is radiolucent, that's why lipomas appear lucent. And then other random findings is they've got a bit of enthesopathy here and here, which is just a bony growth, again, as a result of stress, but this time it's where tendons attach. So the bottom one is the plantar fascia aponeurosis, and the posterior one is the Achilles tendon. Okay, case number 13. Martin's posting some really good links, by the way. I literally use Radiopedia every day. I still have to like look stuff up when I'm reporting because I don't know what it is. This is one of the things I very much like about this request is quite how honest the GP has been, that actually this X-ray is completely useless, but the patient won't stop talking, so can you please just do it anyway? So I think we can all agree that femoral heads do not look like they're supposed to. Okay, there's some other abnormalities going on here as well, which give you an indicator of what the underlying process is. Perthes is not a bad shout, because this is, if I tell you this patient, I think she's in her 70s. This is probably what somebody would look like if you didn't treat Perthes. It's not Perthes though, but very, very good observation. The femoral heads are a little bit non-specific, but there are two things here which are sort of more if I draw something, see if you guys have heard of this sign before. This is called a champagne glass pelvic inlet, which I always found confusing until I realized that probably when they named this, this is what champagne glasses look like, because now they sort of look like this, but in like the 1930s, they look like the one inside the pelvis. So a champagne glass pelvic inlet, along with the appearance of the iliac crests. These are called tombstone iliac crests because they don't sort of go out away from the midline particularly well. They're sort of quite round, but also slightly flat at the top. Oh, lovely. Martin sent a picture of what old style champagne glasses used to look like. We've got this sort of lack of growth where the proximal femoral epiphysis is. And we've also got horizontal acetabular roofs. So whereas a normal acetabulum, oh, that was a rubbish drawing. Hang on. More like that, normal acetabulum. This is sort of like that. So this is a lot flatter. Anyway, let's get rid of all the doodles. Right, this is This is skeletal manifestations of achondroplasia, which is a type of dwarfism. It's the most common type of dwarfism. So there's lots of different kinds of dwarfism. Achondroplastic dwarfism is what we call a rhizomelic dwarfism because it affects the proximal part of the limb. You can also get mesomelic, which is middle. You can get acromelic, which is the end, and you can get acromesomelic, which is the middle and the end. Again, this is more of just an interesting one. Like, I wouldn't expect you guys to know. There are a few more signs that you can't really appreciate on here. If you had a lateral view of the lumbar spine, you'd be able to see posterior vertebral scalloping, which is where the back of the vertebrae kind of goes in like that. You can break, as a word, achondroplasia down. Like A is absence of, chondro is cartilage, plasia is development. So it's a lack of cartilaginous development. Cool. So I just said at the top, I can't actually say what they're actually looking for, which is a coccyx injury. I mean, you can't see a coccyx reliably on an X-ray anyway, which is why we don't tend to X-ray for them. And then I've basically just described what we've already talked about with the achondroplastic dwarfism appearances. And again, that's what I talked about in terms of classification via the area of the limb that's affected. Okay, lovely. This is, again, quite sort of amusing clinical information. Cat bite related injuries. So we can see where the abnormality is. So the terminal phalanx, tip of the finger, does not look like you would expect it to be. Again, we've got a permeative appearance. Yeah, lovely. Alice has spotted it. I think I've sort of burnt you guys too much with the septic arthritis, and you've not said it now. This is actually osteomyelitis because it's only one side of the joint. And the clinical information kind of suggests that as well, because we've got a cat bite, which is a sort of punctuating injury where you have the potential to introduce pathogens from the cat's mouth into the bone or the tissue around the bone. It's just important to distinguish this from a fracture. This isn't a fracture. This is a aggressive process that needs sort of urgent management of antibiotics to stop it from causing any further damage. Interesting tidbits. It's still better to be bitten by a cat than another person, because human bites become infected more frequently than any kind of animal bite. So it's a random little fact for you. So again, we've got a lytic permeative appearance to the terminal phalanx. It's against the articular surface, but there are no destructive appearances on the intermediate phalangeal side, so we're happy that it's osteomyelitis and not septic arthritis. And there's also fusiform soft tissue swelling of the digit. So this digit is, you can see the finger's quite swollen. And that has a name as well, which I haven't put in the report. It's called dactylitis. Similarly to septic arthritis, it takes a while for it to manifest clinically. Okay, nearly there, guys. Case 15. So we can see that the patient's got some metalwork. They've got 2 intraosseous screws, presumably for the previous fracture fixation. And actually the previous fracture is here. It's what you describe as a Weber B, because it's going into the tibiofibular syndesmosis. The talus does, yeah, the talus does look a little bit weird. I don't think that there is anything wrong with it. I think it might be positional. No, Alice has got it. Periprosthetic fracture. So this is the original fracture, and there is a new fracture here. Okay, let's just get rid of that so you can see that's going through just past the head of the screw. So periprosthetic is not, it's a funny term because actually this isn't a prosthesis. So I don't know if this has a name, but I've kind of coined the term peri-instrumental. So I'd call this a peri-instrumental fracture because it's around implanted instrumentation. But I don't know if anyone else actually uses that or if it's something that I've just made up. But good, because that's a really subtle one. Well done. So orthopedic review is recommended, not super urgently, but whoever put those screws in probably wants to have another look. Right, okay, cases 16 through to 20 are probably the most difficult ones, and these are because I designed this with the trainee reporters in mind. And when you do reporting at Cardiff, you have to do what they call a long case exam, where you have to, they give you cases that have differentials. So these are all a bit complex. So I don't think we're going to be able to come up with differentials, guys. I'll just sort of talk you through what we're doing. This is the abnormality. Okay. Its appearance is benign looking in nature because there's no periostitis, there's no soft tissue mass. The cortex is expansile, but it's not breached. It's a bit of a funny matrix because it kind of looks lucent, but it also looks like there might be something else in there as well. It's not against the joint. You can appreciate the top of it there and the bottom of it there. Regardless, the first decision we make is that actually this isn't something we need to be that worried about. This is a completely incidental finding in this case. This is quite a long report that I came up with, so I'll just walk you through it. So I've described it: narrow zone of transition, geographical pattern of destruction, it's expansile, it presents with an element of cortical thinning, but not cortical breach. There's no periostitis. There's a little bit of, it's a lytic kind of fibrous ground glass appearance, and there's a little bit of internal calcification. It's a bit tough because this doesn't really point you in the direction of anything in particular. Rihanna's sort of got a good idea. Giant cell tumor was within my differential, so I gave 3, one of which was a brown tumor, and that's a skeletal manifestation of hyperparathyroidism. One of the reasons I came to that conclusion is if you look at the spinal x-ray I gave you, you can see the disc calcification, and disc calcification is an indicator of hypercalcemia, so too much calcium in the blood, and that happens in people that have hyperparathyroidism. I'd sort of say it's good to do some blood tests, alkaline phosphatase, parathyroid hormone level, and blood calcium, and that will sort of tell you if it's likely to be a brown tumor. Giant cell tumor, this would be an atypical presentation because giant cell tumors are supposed to fit 4 criteria. They occur after the growth plate is closed, so tick. Okay, it's got that one. It's well defined with a non-sclerotic margin. It's sclerotic here and here, but I think that's just the cortex. I wouldn't say it's particularly sclerotic looking at its margin. It's got an eccentric location, which means if it was in the tibia, we wouldn't expect it to be here. We'd expect it to be here. It's hard to tell because the fibula is such a thin bone, but this doesn't touch the articular surface, which makes it an if it is a giant cell tumor, it makes it an atypical presentation. but still, it was something that was worth putting in the differential. And the last one was monostotic fibrous dysplasia. So rather than being sort of a polyostotic fibrous dysplasia, sort of like cherubism or something like that, it's fibrous dysplasia, which is just happening in one bone. I talked this through with one of the MSK consultant radiologists. He thought it was probably fibrous dysplasia, but the patient went for an MRI and we were all wrong. It was another lipoma. Lipomas they're really tough because apart from in the calcaneus, they've got really, really broad range of appearances that they can present with. So that's where MRI comes into its own. Like literally MRI, it just completely identified what it was. If you've got any kind of bone tumor, you tend to do an MRI anyway. Okay, this is a good one. And this is my favorite clinical information. I'm not sure I've seen anyone else that has been injured by picking up a cat. Martin's recommendation of that book is very good. That book basically got me through my reporting PG cert for MSK. It's like really digestible information on bone tumors and stuff like that. So obviously the humerus is abnormal, but I don't know if you guys can also see there's a lesion here, and there's also one here, though that is quite hard to see. This is your main abnormality. Again, the important thing to identify here is that it's not malignant looking. There's cortical thinning, but it's pretty smooth. It's not cortical breach. There's no soft tissue mass. There's what we'd call internal sort of loculation and sort of a lucent / fibrous appearance again. No internal calcification. This is quite easy to tell what this is because there's so many lesions. This is benign, but this is something called enchondromatosis. So these are all enchondromas which have kind of blobbed together into one big lesion. So we go for our checklist again. In keeping with enchondromatosis, most likely Ollier's disease. So there are a couple of types. There's Ollier's disease and there's Mafuchi syndrome. Mafuchi syndrome looks the same, but you have the presence of soft tissue hemangiomas, and they usually present radiographically with phleboliths, like in the surrounding tissue, which is sort of just calcifications within those hemangiomas. Mafuchi syndrome has a higher rate of malignant degeneration because this is a cartilaginous lesion. If it undergoes malignant degeneration, it will degenerate into a chondrosarcoma. You can also have enchondromatosis present with something called multiple hereditary exostoses, and those you might have heard it by its other name, which is diaphyseal achalasia. It's where you get lots of little bone sort of exostoses or little bony growths around joints, and that's called metachondromatosis. Okay, this is another one that came up in hot reporting. And this is a case where I suspected there was something there, and I went and talked to a radiologist and was just like, I think there's something here, and he was just like, no, I think it's normal. And I just sort of ignored him and sent the patient for imaging anyway. This is a really hard spot. If you see this, well done. There is a lytic lesion here, and you can see it on the Y view here because you're kind of looking through it and it's superimposed on top of itself. So if we look at what I wrote, so there's no acute bony injury. Answering the clinical question first, poorly differentiated area of bone lysis in the inferior aspect of the glenoid. I know from the patient's history on PACS that they've had lung cancer, but in the first instance, I don't want to send this patient for a CT, because actually I think we can look at it a bit better with plain film first to see if we need to. And it's worth doing it. You always do a chest x-ray if you think there's a chance of there being lytic metastasis. The reason for that is because the differential of primary malignancies for lytic metastases, you can remember with this mnemonic, which is lead, kettle. So PB, lead, kettle. So causes of lytic bone metastases: prostate, breast, kidney, thyroid, lung. They are like 98% of them, I think. And the other ones are random things like carcinoid, like a neuroendocrine tumor and stuff like that. So I've got some follow-up for this one. It's good. These are my PAX key images. I think I went a little bit overboard with the arrows on this one, but never mind. Patient came back for another shoulder x-ray, and you can see it looks completely different this time. It looks sclerotic, but the angle of the glenoids to the body of the scapula looks really weird, and that is because the patient has actually the fracture it's fractured and impacted into itself. That's what their chest x-ray looked like. That obviously doesn't look normal. Most of that is due to the previous lung cancer, but what the radiologist who reported this noted was there's actually a lytic rib metastasis just here. And sadly, this patient did have reoccurrence of lung cancer. So that's their CT. So those are the lung cancers. And then this is what we were seeing on the plain film. And you can see that the scapula is absolutely riddled with metastases. Okay, second to last case. Obvious thing to note here, nasty ankle fracture, bimalleolar, I think actually trimalleolar. I think you can't see it very well because it's not very good lateral, but I think there's a posterior tibial tubercle fracture as well. Again, this is a lesson in satisfaction of search, but this is not something I would expect sort of a day-to-day radiographer to pick up. Is this. You can see there's a very smooth periosteal reaction going up the tibia. That is something, it's a suggestive of something called HPOA, which is hypertrophic pulmonary osteoarthropathy. That has a few associations. The reason it's got pulmonary in the name is because it's usually associated with pulmonary conditions like potentially interstitial lung disease or inflammatory lung disease. The main concern here would be a malignant cause. HPOA can be caused by something called Paraneoplastic Syndrome, which is where you have cancer and your immune system starts attacking your own body. The most common cause of Paraneoplastic Syndrome is small cell lung cancer. So if you see this, you always send the patient for a chest x-ray. So we just move on. So it's a smooth, undulating periosteal reaction, which sort of has a lamellated or onion skin appearance to it. Usually is caused by a primary lung lesion, but you can have an inflammatory and infectious cause. Also, it can be associated with enteropathic arthritis, which is a kind of arthritis you get if you've got ulcerative colitis or Crohn's disease. Right, last case, guys. I think the third thing you'll notice looking at this is obviously the hips, and this is quite a similar appearance to achondroplasia because this is a different kind of dwarfism. This is multiple epiphyseal dysplasia. This, you'd look at this and think those hips are absolutely knackered. This is a 17-year-old girl. So that's quite bad damage to have. Somebody mentioned earlier when they looked at the achondroplasia Perthes, this is probably a similar appearance to what you'd expect if you had somebody that had Perthes that wasn't picked up and wasn't treated. Here's some knee x-rays as well. This is non-specific, really. The thing with all these x-rays that makes you think it's more like multiple epiphyseal dysplasia is the intercondylar notch. In your normal patient, it's quite pronounced, but when you've got patients with this, it's quite flat. It's got a flattened pistol grip. It might well be. I mean, that pistol, you know, I could certainly see why that would be called a pistol grip deformity. You could well be right. If it is, I'm not sure. Something to look up. I'm not really sure what's causing this. This is probably just normal morphology for the patient, but the trabecular pattern's all strange. Going on to the report. So I've done a sort of combined report here. So yeah, talking about the pistol grip thing relates to this Coccyvarus, which basically is just abnormal orientation of the femoral neck. So if the femoral neck goes horizontally, it's Coccyvarus. If it goes vertically, it's Coccyvalgus. Lovely. And that's it, really. It's also called Fairbank disease. Radiographic features. So this is a non-rhizomelic dwarfism. Delayed, irregular secondary ossification centers. So that's what we're seeing in the hips. Flattened and square off epiphyses. We're also seeing the hips. Thinning of the lateral tibial epiphysis, I couldn't appreciate in this patient. I'm not sure they have it, or I'm not sure if I just can't appreciate what it looks like. They don't have a double layered patella. That's kind of where you almost see a patella within a patella. And hyperplastic tibial and femoral condyles with shallow intercondylar notch. But anyway, thank you for listening to me. Just bleat on about x-rays for an hour and a half. But I'm more than happy